Welcome back to another PCBH Corner. It's been a while since you and I have actually done a corner. We posted some corners, but just been a while since you and I.
I'm super pumped.
I know, I am too. And so Bridget and I, we've had the kind of honor of being able to work with some consulting contracts, particularly in Michigan. And it's always fun because we get to work with great organizations, great BHCs. And then you and I get to just allow our minds to say, okay, so how do we make this work? How can we make this make sense? And one thing that I think always comes up, and we've seen it more within CHCW than also within our consulting work, is medical necessity of getting a BHC involved. You know, this is something that is an important thing for us to always think about, like, do we need to get a BHC involved?
Right.
Do we need to, and usually when that happens, we start listing off, it's like, well, does this person have mental health concerns? Do they have substance use concerns? Do they have any lifestyle or chronic conditions that the BHC can help with? You made an interesting point though, and have been highlighting this more, that contextualizing care is important for everybody. So one thing that I wanted to ask you from the beginning, because my mind goes to so many different ways, about what if we start looking at part of the main job of a BHC is to help the team contextualize care, what that ripples out to. Before we even dive down those roads and those paths, what does contextualizing care mean to you?
Yeah, I mean, so I've been thinking about this for years. I just didn't have words for it.
Yeah.
So if you rewind back into 2017, 2018, what I found a lot of times is when I would go into these visits, if a patient wasn't necessarily in a position based on their context to work on something actively or do necessarily a coping skill, sometimes we could do more subtle interventions in terms of what somebody was willing to try this, or they were going to turn in a resume, or they were going to do a couple more chores around the house. So sometimes you could, you're able to get, I always think you can get somewhere. But in terms of looking at it as like, oh, this person is doing treatment and they're doing a full-on X, Y, or Z, I found that so many patients, it just didn't really make sense based on their context, but I felt that those visits were still deeply meaningful to be able to come out of the room and say, hey, look, the patient isn't ready to quit smoking. However, they're going through a divorce right now, and they're doing everything they can to ensure that they have custody with their kids. And so they're trying to follow up with their lawyer, and they're working with their sister to help take care of the kids. So to me, those are really important things. So that's when I was saying, like, well, they might not be like ready to work on something, but they're working on something. So them getting the lawyers and talking with their sister about watching the kids, I look at that as doing something really important for a person's life, even if they're not ready to start deep breathing in order to reduce their smoking cessation.
And can I pause you on that? Because I think this is a big thing for BHCs and PCPs as well, both. We'll say any provider working in primary care.
I'd probably say even the medical assistants.
And the medical assistants, it's great. The whole team, whoever's working in healthcare. It is an interesting thing that, who knows if this is true or not, my mind just says it has a higher probability of being true. When we define a successful visit, typically is if we gave an intervention, and usually an overt one. And as you said, maybe even a subtle one. And though it's like a lot of things that are connected to good care, good visit, is when we leave the room and it was very, very obvious we gave that patient an intervention. We gave them psychoeducation, we gave them medication, whatever it is, right?
That's true.
What you are describing, though, is the importance of, hey, that's important. That's not to say not to do those things. I don't know if it's equally as important, more important, less important, it doesn't matter. It's just that it's an important thing also just to understand where the human is coming from.
Yeah.
What's going on with the human.
And that's what, to answer your question, I feel like that's what contextualizing care is to be able to meet with a patient, learn about their life, their circumstances, their situations, what's important to them, what they're working on. And we didn't have this word until, I think, wasn't it just recently that we got?
Was it Carl?
Was it Dee Dee?
Maybe it was Dee Dee. Maybe it was Dee Dee. I think it might have been Dee Dee, our CMO. Shout out Dr. Ebert.
Yeah, and she sent over this article written by a physician, actually. I believe it was a physician, and they were talking about the importance, kind of from a medical perspective.
It was someone that was going through like weight loss surgery or something like that, and then they found out that the person was taking care of, I think, their older son or something like that, and it would like, obviously after weight loss surgery, you're not going to be able to move things, or you got to recover, and that wasn't something that was possible for her as she was caring for her son.
And they talked about some of the bad outcomes, and I don't know exactly what words they were using, other than, I guess, bad outcomes, happened because of a lack of contextualizing care. And this was all written from a medical lens. And when I read that, I'm like,
that's what we're saying.
That's what we've been trying to say. The amount of times that I've sat or stood wherever in a training and said, we have to redefine our idea of like what success is as a BHC. That even if, again, the patient isn't able to do a coping skill in the traditional way, it doesn't. I always say that nothing is ever lost. Because to me, going in and learning about a person's life, having that deep connection goes to what you always talk about, patient engagement. So who even knows what's going to happen there? And then to be able to understand the circumstances and the situations for why they might be working on something, not working on something, want to work on something but not able to, or whatever the situation is, for me to go have those conversations and come back out to the medical team and say, hey, here's what's going on. So let's take that into account, let's contextualize care. Let's not do something that the person can't do.
We talked about this in other corners, and obviously part of Access V and with the stages of change being a part of that. To be able to say, hey, this person isn't ready, but not have it stop there. They're just they're not ready. You know, I told them when you're ready to work on something.
I'm planting seeds. Maybe someday they'll work on themselves. Like that doesn't feel good.
It is more to, as much as we can, to understand why the person's not ready. What's causing that person not to be ready?
What's the circumstances? What are the, you could imagine a cognitive behavioral therapist in terms of the circumstances, the situation, the triggers. Like, just what are all the conditions for why something is or isn't happening?
And what's interesting about it is that when you start to dive into the research about just what allows higher probabilities to successful outcomes, while they might not use the word contextualizing care, it's there, right? Again, you look at the substance use treatment. It's like, hey, shared decision making, understanding what the multi-morbidities, understanding the patient's values and their desires about what they want to do.
Do something practical.
Do something practical, which inherently almost says, like, if you're going to be practical, you got to know what a practical intervention is. So you need to know the person, i.e., you need to contextualize their care.
What's practical for one person isn't practical for another.
Correct. All the lifestyle things where we know just this education about like diet and exercise, this is what you need to do. What point of care resources will say, it's like, that's great. And the best thing is practical, pragmatic, and what's possible. Which again, inherently within that means you have to understand the patient's context and what they're going through.
It's amazing that so much of this stuff is coming from the medical literature.
Yeah.
And behavioral health, mental health as a field, it seems like we are not keeping up in terms of what we look at as success, what we look at as helping somebody improve their functioning. It seems like it's always about how to get somebody into counseling or therapy or process this trauma or that trauma. Again, not saying that those can't be super useful,
correct,
but we have to have a field of I guess, what word am I looking for? We have to have a field where we're able to be practical and helpful to populations, like the whole population, not just 8% or 13%.
So I think that's why I get so excited about this topic, because it's based on our consulting and stuff. And again, we're working with a variety of different BHCs, some of them brand new to the role. And one of the things that always shows up with that, and we're onboarding even our new trainees right now, right? And we do every single year, is confidence, right? That they have confidence they're going to be able to help somebody. And so if someone comes in and they have whatever it might be, like a very, very overt behavioral health thing or whatever, the confidence goes up a little bit because it's like, oh, okay. But then they get in the room and it like gets punched in the face because like, oh, this person doesn't want to work or anything. They're resistant and stuff. Then they come out of the room and the medical is like, well, what'd you do with them? It's like, we didn't get anything done. They weren't ready, right? What's interesting is that when we start to shape our job, and an important part of our job, maybe the most important part of our job on this team, is to contextualize their care. I think that takes a lot of pressure off of us. I think that
gosh.
takes a lot of pressure off of new BHCs. It takes a lot of pressure off any person in the medical team that's just striving to do the contextualized care, because your job is to go in there and just learn about the human, about what they're going through.
Almost have to like change the entire aim.
Yes.
Of what we're even trying to accomplish. I've never gotten more done with patients, actually, almost kind of from like a behavioral health intervention lens, when I don't go in trying to do behavioral health intervention.
Correct.
Like
I'm not trying to go in there even before we get to the behavioral health intervention. Sorry for interrupting you, but I'm going to gather symptoms to get a diagnosis, and then I'm going to do the behavioral health interventions. To not do that, and to move towards what you're saying, like this is when I start to contextualize care. What it does for you.
Yeah, and it's so funny. It's like the motivational interviewing or anything else, that you can't go into it being like, all right, I'm going to manipulate them into doing behavioral health interventions with me. So how I'm going to do that is I'm going to disguise it as caring about their life. And then once I pretend like I care about their life, then I'll sneak in my interventions.
I'll weaponize that.
Yeah,
right?
You always say about weaponizing motivational interviewing. It's like, no, when you say that this is a dance and a non-judgmental stance, like we literally mean that it is okay that the person lives their own life. So when I do take that stance, that clinical stance of, I literally am interested in you, I'm interested in your life, I assume that everything you do makes sense, you make sense, and I'm really interested and curious about what's going on. And I'm curious of what I can reflect back to you, so you can hear yourself say these things, and then what direction you want to go. When you do that, there are so many more opportunities for there actually to be an engagement.
Come on.
In the visit, and maybe even do like more of a classic intervention, but that's never my goal.
Correct. While the universe opens up to allow that, yes.
Yeah, the aim, the goal is to understand what's going on with the patient, to make, dare we say, what do we always say the type of care that we want to do? That we want to provide contextual and compassionate health care.
Hell yeah.
So when you triple down on contextual or compassionate and contextual, or do you always say contextual and compassionate?
Contextual, compassionate.
When you triple down on contextual and compassionate health care, all of a sudden the conditions are ripe for somebody to maybe work on something. But even if they didn't, nothing like I was saying is ever wasted.
Resistance, even in that point, like isn't resistance.
Yeah, and I'm not upset about it.
No, and again, it's a behavior that makes sense within that context, right? Like it's not this behavior that's just floating out here and that we hope just disappears eventually so we can work with the patient. That is such
a good point. I don't know if you want to expand any more on that.
Well, I guess the idea where it's almost kind of like we've said about like the behavior of suicide, right? When we bring the behavior of suicide back into the realm of expected human experiences, like Kirk conveyed, when we bring the behavior of resistance back into the realm of expected human experiences, like, as you said, the universe opens up. Like we have so many different more opportunities. And, we were talking about this past week with the group that we were working with. When we approach care this way, you know how you said those two questions, right, that we always try to ask ourselves, right? How do they make sense? How can I enjoy this human being? When we go into the room unapologetically, just infinitely curious about how this person makes sense, visits are fun.
Yeah.
Visits are fun because there's nothing that I'm trying to convince you to do. There's nothing I'm trying to wrestle you in.
Exactly.
It is 100% bought in. I'm trying to help you.
And what do we say across pretty much everywhere in healthcare? If you were to poll people, and the question that we always ask, like, what do you think that people want out of care? Almost always, somebody is going to say non-judgmental listening.
I'm seen, I'm heard.
We want to, what's hard to do when you're talking with somebody is be non-judgmental. Like just in general, like if you're just talking or thinking about a person's situation, especially when you don't know details, it's really hard not to be a little bit judgmental. The minute somebody starts saying this or saying that, as a human being, we're kind of going into kind of a judgment evaluative mode. It's just like human nature. However, when you, again, triple down on, I want to know about what's going on in your life. I want to know the circumstances, the situations, what's showing up in your brain and your body. That's how you get to non-judgment.
Correct.
That's how you get to non-judgment.
Because it is non-judgment.
Because when you hear a person's circumstances and you see things kind of playing out, and then kind of wherever you're maybe stuck on in your mind of like, wait, that whenever I think to myself, wait, I don't know if I understand that, or that doesn't quite make sense, I normally try to go like a step further and just say like, wait, so like, and not like, wait, so what's going on with you, but more like, oh, wait, so is that getting in the way? And not like, is that getting in the way, but like is that
actually,
getting in the way?
As another human being curious about that, like that's a huge thing. You were talking about this past week as well, where when we get taught so much, like someone dies, right? We get taught and we say, oh, I'm just so sorry, right?
Sorry.
Like, it's just like an automatic thing. What's interesting about that is that I don't think that's actually reflecting seeing, hearing, or having a non-judgmental stance. If you just do it again as an automatic thing that you are trying to do, that's not non-judgmental, that's not hearing or seeing. That is just you being on autopilot with it. However, if there is an understanding of what that person meant to that human, now they pass away, now it becomes, oh, what is that like? How is that hitting you right now? And it's felt. Even by your existence, by the questions and the follow-up with that is felt. That's now having the person feel seen, heard, and is non-judgmental.
And full circle, this brings me back to our postdoc days. And I remember there was a woman that was in a lot of distress, and I wasn't sure the circumstances that she was in distress about at the time, because she got referred to me and I'm like working with her and I'm barely even asking any questions. She's sobbing. She's in a lot of distress. This was like 12 years ago, so I don't remember the exact specifics. But I remember sitting there being like, and I had Kirk shadowing me. I remember sitting there and being like, oh, like, I'm so sorry that you're feeling this way. And like, hey, like, I'm a nice person. You can talk to me. Obviously, I didn't say I'm a nice person, but I was trying to convey I'm a nice person. I have a soft, gentle being. And I thought that was really conducive to healing, because that's kind of what we had been taught. And not saying that that's not the case. And I remember afterward, somehow I like crapped my way through the visit. It was like a 45, 50-minute visit. Who even knows? Eventually, not because, like you always say, not because I did anything with strategy.
Accidentally, we fumbled and bumbled down there. Yeah. Yeah,
so she told me about her life a little bit, and then we ended up coming up with something decently important. She left better than what I found her, and so I didn't think it was like the worst visit ever, but I did know that it was clunky. And that it was way more drawn out than it really like needed to be. And so I remember Kirk and I were debriefing about it. And he was saying like, kind of like, why wasn't I asking the questions that we had like probably just practiced? And I said, well, she was crying. She was in distress. He's like, Bridge, like we have a responsibility to help people. And our responsibility to help people is going to be contingent upon what's happening in their life and knowing the factors that are happening in their life. That's the best way we're going to be able to help somebody, a la if you know their context, which is why we have the love, work, play questions. And that's why when you go into the room, you ask these questions, is because then you're going to know the person's circumstances. And then when you know the person's circumstances, you can actually be
with them.
Of help.
Correct. You could be with them. You know how you were saying, like, you conveying to the person, oh, I'm so sorry that this is happening.
I was sorry that she was in distress, but if I understood why she was in distress and the circumstances and the conditions that arose for her distress, I would be able to empathize 1,000 times better.
I don't know if this makes sense or not, but it almost is kind of like you can either be on the moon or you could be on the actual planet with the person, right? So the person themselves is on the planet. Right. You could be on the moon just yelling from a distance, oh, that seems hard, that seems really difficult, I'm sorry. Or you could be on the planet with them and actually understanding like what this world is like as much as possible. Yeah. As much as possible.
I love that.
And that is a way of conveying something. And so I think the important thing like coming to, because I think we just put a lot of pressure on ourselves as providers. And Bridge, you've been saying this for a while. I mean, we've gotten into this with other people about this, where it's like, hey, sometimes just doing the contextual interview is the best thing that we could do for it. And people will say, no, you got to give interventions, right? You got to do different things.
I feel like such a fraud because I'm over here like PCBH. Oh, I'm a PCBHer, which of course is like, we teach in the structure to have an after visit summary with action items. So then I kind of feel like a fraud there, but I'm talking out of two sides of our mouth. But sorry, go ahead.
So, well, two things related to that. One, it's not saying not to do interventions.
That's true.
It's just making sure to say, know when to do interventions. And two, the other thing that comes up, you talked about that after visit summary. If you live within the world, if you're able to take that spaceship down to Earth and be with them, you're still going to come up with after visit summary goals.
True.
it might be the things that they're already doing, because it would make sense just to focus on, let's keep the status quo right now. Let's build this up. Let's have that mirror be reflected that even though it doesn't seem like you're doing a lot,
from what
I'm hearing, you're doing a lot right now. Maybe this isn't a time to do more.
This is like an intervention, non-intervention, intervention of non-intervention, intervention.
Yeah.
Being able to help somebody to see that so many of the things that they're doing is actually an investment in themselves. Like you said, with that mirror, I literally was saying that this past week of like, if you even harvest what they're already telling you, and then you're able to reframe it back of like, oh my gosh, you've made these steps, you've done these things, you're doing this. That to me is an intervention, even if we're not adding anything.
We've talked about these in other corners. When you're able to do that, what's really interesting, one, there's a decent amount of research about self-efficacy, right? If someone feels that they can do something, like they're more likely to do it. What's interesting, when you can be that mirror and reflect that back to them, that grows within them. They're like, I guess I am doing some things that are happening. Like that's a very, very powerful intervention. And I have found when someone notices that someone else is recognizing the work that they're doing, it actually produces a universe that they're more open to be like, maybe I should try to do some more things. Now, if that happens or if that doesn't happen, that's, as you said at the beginning, not my goal. It's almost like the fight to try to convince you that I'm overwhelmed, I can't do anything more, is put down because I have another person that is, I have another person.
You stay
how was that doing?
You were doing really bad.
I have another person that can now sit with me and understand what I'm going through. So maybe I can partner with this person to come up with some goals. Now again, if that happens or doesn't happen, that's okay. I have just found anecdotally, when we let down that rope and that person feels that kind of that tension lax on that rope, there is more openness to try new things.
Well, the irony is this is what we're taught in counseling and traditional psychotherapy.
We've forgotten.
But for some reason, for some reason we thought we had to go through a completely different journey to get there.
Yeah.
That it needed to be contingent upon time and long intakes and long diagnostic process. Isn't that so interesting? Like if you go back to those very, very first courses that we took, and you're looking at basic counseling skills and says, these are the common factors of this non-judgment, this listening, this joining, this partner, this alliance, the therapeutic alliance. And then you think about how, I know that you've been hitting this hard in a really good way of like, then you look at how our services are set up, and when I say our, I mean like the field of mental health.
Is that reflected?
Is that reflected? Versus when you get one shot with somebody, statistically, the most common scenario is you're going to have one shot. Maybe you get up to 3 or 4. Maybe you get 5. And so if I'm going to put my bet somewhere of where I'm going to put my time and where it's going to get the biggest bang for my buck in terms of helping somebody, it's going to be on learning about the person's current world.
Come on.
Of course, past stuff could come up, but their love, their work, and their play.
Absolutely.
Versus asking about if their great aunt had a mental health disorder.
Correct. And, it's so funny, even when we ask about that, it's like, well, I'm sure that great aunt had a context that was probably produced in some of these things, but what do you even ask about that, right?
Yeah, like think about these intakes, think about this whatever, and then PCBH in this approach is seen as less than. Why?
So my mind goes, it's like, when we go back to, it's like what we were taught originally, one of the biggest problems, we talked about this, I won't go down it, another rabbit hole, because we're trying to produce cooks, not chefs, where we want to produce chefs, not cooks. So we almost teach those like basic counseling skills, whatever those
devoid
things.
Of
no philosophy whatsoever about why we're doing that.
We're just being nice to somebody.
Yeah, because it's good to be nice to somebody. The other thing that as we begin to end, just encouraging BHCs, encouraging any provider in healthcare, double down on getting to know the human in the context. Double down, coming down to the planet, to be with them, to understand them. Contextualizing care, and what's interesting about that, as we said, the research about contextualizing care literally starts to show we need to contextualize care with everybody.
I want to dig more into it because again, like I said, I think it's coming from the medical side of things. Correct, because
they are recognizing oh man, our treatment here is ain't great.
Something.
Yeah, this is a good one.
And we could be that missing puzzle piece to help with it.
What's great about that is that if you're a BHC and you uptake this, now you can help everyone, and you should. It doesn't matter what the presenting concern is. It doesn't matter what the thing. It literally starts to promote. It's like, oh, I can help everyone, and I should help everyone. That's good healthcare.
I think that if every single person went into their doctor's office, where you're talking about very vulnerable things, and somebody sat with you and asked you about your living situation, your relationship, your friends, your family, your belief system, what you did for an income or work or school or volunteer, and what was important in terms of your passions or hobbies or interests. And then, of course, you get bonus points if you get some diet, exercise, and sleep in there. If everybody was that interested in you as a person, what was it we were saying a few months ago, that when patients come in, they should feel like a celebrity? I think maybe a patient wrote that on a comment.
Yeah.
It's like, oh, I feel like
a celebrity.
Yeah, you know, you're getting this like red carpet treatment. And what better way to invest in somebody than to ask them about their life? And so from that lens...
In an interesting, curious way, not just asking about their life to check a box.
Oh, yeah.
Like with intention,
with
purpose.
Don't ask something that you're not going to use.
Come on.
You know, that's just like, I think Jeff Wright always says, like, voyeuristic. It's like, I'm just asking you about something, or, you know, and look, we all have to do some things for check boxes. I'm not saying that that's not a reality, but if somebody took an interest in who you were as a person, especially if we are trying to do person-centered care, that could be a huge game changer. And what better field of people?
What better field?
To learn about a person's biopsychosocial, spiritual, cultural context.
Bridge,
but we're missing it.
You know, that's
going to take me down like a negative road, but I do think we're missing it. I think we need to get it back to the planet.
I think because of the way that we train and how we teach this, it's like, oh, you got to integrate within primary care because you're going to be the behavioral specialist. It's going to give all these interventions out for lifestyle and all these different things. And it's like, again, I got to stop saying the word again. It's really making me upset that I'm noticing it right now. We want to be able to deliver behavioral interventions that are backed by research. Absolutely.
Sure.
This is not saying not to do that. It is simply saying at the beginning, let's just make sure we're contextualizing care so we know if and when a behavioral intervention is going to make sense.
And dare we say, it is going to grease the wheels in terms of having uptake of behavioral interventions.
Come on.
Again,
it increases the probability.
It can't be the goal. There was something else that I was...
Think about it, because the last two things that I wanted to say. One is that we've talked about this regularly. What happens when we come out of the room and we're able to convey back to the PCP what the context is, how much not only do they appreciate it, their frustration with the patient goes down, and we've said this in other corners, how much PCPs now actually ask us just to go in and contextual interview the person. Because that's vital now for them.
Because they're asking us to go contextualize the care.
Which loops into the final thing about, this is what the National Academies of Science, Engineering, and Medicine called high quality primary care. Was relationship-based care that was person-centered based on the needs, preferences of individuals, families, or communities. If we don't understand the planet that the individual is living in, how are we doing that?
Yeah, and I did remember what I was going to say. It was just that it's interesting when BHC roles and therapists or traditional are juxtaposed. It's kind of seen as mechanical, medical, cold for the BHC, and then for the traditional, that's where the warmth and the kindness comes in. And what we're saying is, you should have warmth and kindness at baseline, and that by coming in with a smile, knowing you're going to help somebody, conveying that, saying, I'm here to support you, I'm going to ask questions to get to know you. You triple down on their context, learning about their love, their work, their play, their health behaviors. When you do that, the connections are deep and they're real. And that's why anybody who works in BHC land and PCBH and stuff, they get so upset. Like anybody who's like, I'm a BHC, and they know the work that they're doing, and then they hear it from somebody else being talked about who doesn't do the work, and
it's frustrating.
It's so frustrating because it's like, you're not there with me. You don't know the connections that I have with my patients.
Come shadow me for a day.
Yeah.
See what comes up.
And I think the last, 4, 5, 6 shadowers I had, the biggest feedback that they had for me when we were done was they could not believe how relational the care was. And I kind of was like, hadn't even thought of it. What, after like the third time, somebody was like, man, the clinical care is really relational. And I was thinking kind of like, well, as opposed to what? Not like picking on them or anything, but just like, of course it's going to be relational, because that's what we're doing here.
And it makes me think about what the person said recently to you. The visits were fun.
Yeah.
There was fun that was there. And the reason why they were fun is because of that human connection, because of that infinite curiosity coming down to the planet.
So I actually think, regardless if you are in PCBH, some other integrated care model,
it's a great point,
especially or traditional, I know that sometimes we're confined by some checkbox situations, but doing everything you can to mitigate that and reducing that and being able to triple down on a person's life and having your rapport be the exchange through learning about them and the curiosity versus necessarily just time, I think would be it's beneficial for everybody.
And I think the moving away from my job is to try to, get symptoms and diagnose and implement an algorithm. Your job is to contextualize care. That's what your job is.
I like that.
Come on, let's go. Got me hyped. All right. As always, let us know comments, thoughts, where people's minds go. This was fun. Let's go. We really appreciate you stopping by.